My name's Ethan. I'm a physician and emergency medicine physician. I work primarily in the emergency department. I'm also certified. I have a wilderness medical fellowship background, EMS fellowship trained in pre-hospital medicine, ground ambulance, fire department, and flight medicine, things like that. And we're going to be talking about backcountry or kind of survivalist medical care when we have limited resources. So I'll let Nick introduce himself as well.
My name's Nick and I'm a paramedic. I work locally for an EMS agency, really rural based, and so we do a lot of outdoor medicine. That's pretty much all it is for myself, but going on 6 years of experience.
So we're basically going to give you guys introduction to how to take care of someone in a resource poor area, or if you're, let's say you're hiking, you're up on some trails, you're out hunting, and you come across someone who has been injured. Maybe you're part of a search and rescue team, maybe you're in a more formal situation where you're providing medical care, but most people come across people who have been injured or have someone in their party get injured. And so it's critical that we be able to think, rather than panicking or kind of freaking out about what we're going to do next, have kind of a set stepwise approach to how we're going to take care of the patient that we find laying on the ground while we're hiking, or that slips and falls down a gully while we're hiking and we need to go take care of them. First and foremost, we have some things written down here on the whiteboard, and basically this is going to be an overview of the MARCH mnemonic, M-A-R-C-H, and that is massive hemorrhage, airway, respirations, circulation, and hypothermia. But first and foremost, before we even get into our MARCH mnemonic, the most important thing that we need to establish is scene safety, and make sure that we're in a location, we're in a situation in the environment that we're in that allows us to provide medical care. And if we're not in a situation or an environment that is safe, then we need to be moving ourselves, moving that patient into a place that is safe, so that we as medical providers don't become a patient ourselves. And so make sure your scene is safe before you even start taking care of someone else. Otherwise, you step back and step off that rock ledge, you are in a live fire situation and there's bullets whizzing around you. This is not a place where we should be providing medical care. These are places where we need to find safety and then provide medical care, so that we can give good medical care and actually try to get that patient into the definitive care that they need, basically. The first in our mnemonic is the M, and that's massive hemorrhage. And the reason that we address massive hemorrhage even before airway and before respirations is because that's the most likely problem that we are to encounter, is a traumatic injury with a hemorrhage of blood that could cause the patient to go into cardiac arrest or lose so much blood that they die. And these are things that we can easily intervene on. These are things that we can easily stop that bleeding. It's just a matter of knowing how and having the tools with us to be able to adequately manage that bleeding. The primary way, if we have the resources available, the best way that we can use to stop bleeding is a tourniquet. Now, if we're having some venous bleeding, if you cut your forearm open and you got a little bit of bleeding and you put a gauze dressing on there and you hold a little bit of pressure, maybe you don't need a tourniquet. If that adequately stops the bleeding, you wrap a bandage around there and you secure that gauze in place. You may not need any more than that. And in a lot of small wounds or even larger wounds, that's all you need is a little bit of pressure to allow that blood to clot and stop the bleeding. Maybe that bleeding continues, it's bleeding through your bandage, but it's not squirting out, it's not pulsatile bleeding like we worry about with arterial bleeds. And maybe you have a clotting dressing or a coagulant dressing that you can put in the wound bed, and that will allow the blood to clot off and stop that bleeding. You can wrap it with a t-shirt or an ACE wrap and help get that patient to definitive care, to an ambulance, to an emergency department, something like that. But if we have pulsatile bleeding, if we have heavy blood flow, if we find a patient laying in a pool of blood that looks pale and they're a little confused, this is dangerous and life-threatening bleeding that can lead to low blood pressure, can lead to cardiac arrest. And we need to address these things more aggressively. And that's where our tourniquets come into play, is for that heavy bleeding, that pulsatile bleeding that we need to stop right away and get that under control so we don't lose any more blood. So Nick's going to tell us about a cat tourniquet.
I want to go over bony prominences because you're not going to be able to tension it down enough. They're not comfortable. Anytime I've applied these, people usually they don't realize how much it's going to hurt, especially when the person's already injured. You got to cinch this down, and that's even before I started to tighten it down. I usually just get my tail out of the way just because it's one less thing to get caught. Then you have, this is what they call the windlass. You start spinning this up, and it's going to start tensioning down. Where it has the little white tab here, it says time. It's got little hooks that you can latch it underneath there, and that's just going to keep it from coming unspooled. And then you have your little white tab here. It's kind of important. Back when they started to use tourniquets commonly in the civilian population, they used to think that you really only had, well, it started off with, as soon as you applied a tourniquet, that person was pretty much going to lose their limb, just due to ischemia below the site of the tourniquet. And then it kind of morphed into, you had 3 hours, and then it's kind of gone 6 hours, and then they're realizing that if done correctly, you can actually have some really nice reperfusion, and the odds of them losing the limb due to the tourniquet placement is not that high until you get into, it's been on there for a long time. Knowing that you've put it tight enough when you're done, simple way, you're going to stop seeing the bleeding. I mean, obviously there's going to be blood that's oozed into the injury site, but if it's an arterial bleed, that's going to stop pulsating. You'll know you've gotten it tight enough then. Anything else?
No, that's good. So I think the important thing here is there's a difference when you look at a bleeding wound in venous bleeding that is typically oozing, like you're just like, man, it's just kind of flowing out of the wound a little bit, and arterial bleeding that tends to be pulsatile. So we've got this that rapid pulsatile bleeding that's going to kill somebody very quickly. Even if it's a very small cut and you've got pulsatile bleeding from that site, that's going to result in massive hemorrhage very quickly, and that's something we need to get control of. When Nick talks about not putting the cat tourniquet over bony prominences, if you have a cut in your forearm, you fell, you rolled down the hill, you hit a tree, it ripped your forearm open, you've got a nasty gash, you don't want to put the tourniquet around the elbow because you're not going to get proper compression of the deep arteries and the deep veins if you're putting pressure on the end of the humerus, the end of the ulna, the ulnar head. So we don't want to put the tourniquets around bony prominences. We want them like on the long bones essentially, so that we can get adequate compression of those areas. If the person hasn't complained to you, if they're awake and they're talking to you and they haven't complained about how tight your tourniquet is, it's probably not on there tight enough. And one of the main issues we run into with tourniquet placement, we see people come in the emergency department, they had a tourniquet placed, they had a t-shirt tied around their leg or whatever it is, and in almost every circumstance when that person isn't like military or EMS personnel, the issue that we run into is that it wasn't placed tightly enough, and we're still having some oozing bleeding despite the tourniquet being in place. So it's important to not only put that on very tightly to stop the bleeding, but also to recheck, because as we put that tourniquet on Ellie's leg and we're trying to hike down the hill and support her a little bit, as we're hiking back down the hill to get some help, that's going to loosen up, and so you're probably going to see that bleeding increasing as you're moving that patient from one site to another. So that tourniquet needs to be rechecked and retightened to make sure that we're still stopping the bleeding.
So if you have that injury on your forearm, is it bad to put the tourniquet above the elbow, or does it need to be below the elbow?
Yeah, either way is okay. The current recommendations for like ideal tourniquet placement is technically about 2 inches above the side of the wound, because that's going to preserve the most of the extremity if we do run into that decreased perfusion down in the limb. So, if, let's say for instance, you put a tourniquet on, it ends up having to be there for a prolonged period of time to prevent that patient from dying, it would be much better if we had the tourniquet, if we had a wound right here, if we had the tourniquet here rather than having the tourniquet at the shoulder, because then we're getting good blood perfusion to the upper arm. We're just limiting perfusion to the lower arm. So if you can put the tourniquet just a few inches above the wound, that's great. But the reality is, if you put it above the elbow, if you're like, gosh, I don't have room, there's a bony prominence here and here, I don't know if I can get it in there, just put it above the elbow, and you're still gonna, all the arteries are moving this way, right? And so if you get it clamped down and those arteries have enough pressure to stop the bleeding, you're going to stop the bleeding with a tourniquet above the elbow on a wound that's below the elbow. So wherever you can kind of most safely crank down that tourniquet properly and avoid the bony prominences is going to be an effective place to put it, basically. If you can't comply with the 2 inches from the wound or 3 inches from the wound, that's okay. Get the tourniquet put on at a site above the wound to a tightness that's going to stop the bleeding. And then if you can, note or write on these CAT tourniquets what time you put it on. Because when that patient gets to definitive care, when I see this patient in the emergency department, when I talk to my trauma surgeon about what we need to do for this injury, that time that the tourniquet's been in place is going to change how that patient is managed. So it's very important, even if you can't write it down, you don't have a pen,
Make note of it.
Make a mental note of it and just relay to the medical personnel when you see them, this is what time that tourniquet was placed, because that's very important on our end. Does that make sense?
Additionally, it's not super common, but there can be times that after you've placed a tourniquet, one tourniquet may not be enough to manage the bleeding. It's happened before, you've tightened this down, you're not really able to tighten it down anymore and the patient's still bleeding, in which case it's not a problem. Put a second tourniquet on up above the site of the first one, do the exact same thing, you're going to tighten that one down, and hopefully that gives you enough to kind of staunch that bleeding a little bit. Do you have any issues with applying this for non-arterial bleeding if it's significant enough that you're not able to manage with direct pressure?
I don't. So Nick was talking about the history of tourniquets and there being a lot of concern about limb loss, like in decades ago in the wars and things like that. The reality is, if you put a tourniquet on and it needs to be taken off, we'll just take it off. And usually, if you bring a patient to Nick may keep that tourniquet on in the ambulance. By the time he gets to the emergency department, we're going to take it down and see what we're dealing with. And if we don't need that tourniquet in place, we'll just take it off. So that's certainly not the end of the world to put a tourniquet on if you think that's what's needed. Even if you can't tell the difference in arterial and venous bleeding. Does that kind of make sense? One issue with, when we talk about tourniquets, the question comes to mind, could we just apply pressure and not have to put a tourniquet on? And in a lot of cases, in smaller wounds, smaller areas of bleeding, a tourniquet may not be necessary. But if you have a heavily bleeding wound in a patient that you need to get down the mountain or off the ski slope or to the highway so that you have some cell phone signal, that pressure, the question is going to be, can you keep adequate pressure on that area while you're moving to get the person to that definitive care? And if the answer to that is no, then maybe a tourniquet is the necessary next step. Because if Ellie's got a cut in the back of her knee that's bleeding heavily, she's not going to be able to hike herself out and hold pressure on the back of her knee to stop the bleeding adequately. And then after a mile of hiking later, Ellie's starting to get confused because of the degree of blood loss. And now we don't just have a bleeding wound, we've got a bleeding wound, a confused patient that can't move herself anymore. And we've just our situation has gotten exponentially more complicated. Does that kind of make sense?
This whole thing of March kind of came around in reviews of traumatic incidences. Bleeding is the #1 preventable cause of death. They find that this came around with school shootings, unfortunately, but they found a lot of these patients, they're sustaining an injury and they're not able to have this care provided to them for hours and hours because law enforcement is busy securing the scene, making sure it's safe. And they're finding that a lot of these patients had preventable causes of death just because they were laying there and they weren't able to manage their bleeding. So that's kind of where this whole thing came around.
Yeah, and a lot of, in doing training with SWAT teams, tactical teams, things like that, kind of in New Mexico and in other locations, the massive hemorrhage is kind of the primary thing that we're trying to address. So a lot of tactical units will carry like these handheld med kits, and you could just literally, as you're moving through this tactical situation, toss a med kit to somebody so that they can put on their own tourniquet and keep moving so that we're preventing massive hemorrhage from killing that person, and we can come back to them later after the scene is secure and after we're in a safe environment to provide the rest of care, because that massive hemorrhage is what's going to kill them first and most quickly, and is easily, in many situations, is easily preventable.
If you put on 2 tourniquets, can the one be right above the other, or does it have to be higher?
Yeah, usually you can put them kind of right above each other. Usually I would go, you know, if you have bleeding in the forearm, you don't think you can get it, just for example, right? You don't think you can get a tourniquet around here because you're putting it kind of right on the elbow, so you throw one here. I'd probably give yourself just a little room so that they're not stacked right on one another, or not kind of, one's not causing one to be a little uneven. Give them a little bit of separation and just put one a little bit higher. You could also kind of go just up by the shoulder. It's not like the exact location isn't rocket science. It's more just getting it tightened down, getting that windlass tightened so that we're not having any further bleeding once that's on there. And I think a good question you need to ask yourself, a lot of times, for instance, in my search and rescue med kit here, I carry 1 cat tourniquet. And so I feel pretty confident in my ability to stop extremity bleeding with a single tourniquet, because it's about proper tightening, proper placement, and proper tightening. And a question that I think you should be asking yourself, if your 1 tourniquet is not stopping the bleeding, is how can I loosen this up, place it in a better location? Maybe I've got it on the elbow, maybe I need to move it up. Maybe I've got it on the elbow, I need to move it down a little bit. And I probably, in almost all cases, I probably need to tighten it more than I did. And sometimes that means the person that you're stopping the bleeding for is gonna be screaming and angry at you. And that's the cost of doing business when you're trying to save somebody's life. So they may not like it, but you tell them ahead of time, and you crank that thing down until that bleeding has stopped. Make sense? Other questions? All right, for the sake of a little bit of time, we're going to keep moving here. So the next one that can be a little bit tricky for us to address when we don't have a lot of medical training, but is still crucial, is looking at the patient's airway. So let's say we have somebody that we were out hiking, slipped, the trail kind of crumbled on the edge, they rolled down about 100 feet, they hit a tree, they cut their arm open, we've got a tourniquet in place on their upper arm, we've stopped that bleeding, and they're laying there, they're still a little out of it. We need to make sure that they're breathing adequately and that they are able to communicate with us appropriately, to make sure that it's okay that we start moving that patient down the mountain, for instance. The best assessment for an airway is, can the patient talk to you? So if I came up on Nick and he was laying on the ground and he had clearly been injured, and I was just out hiking, I'd say, hey, what's your name? Are you okay? And Nick's ability to tell me his name and tell me what happened is going to tell me he doesn't have any significant injury to his neck, he's breathing adequately, and it's going to tell me if his mental status is normal or if he's confused. And if I find Nick laying on the ground after an injury, maybe it looks like he's been there all night, not able to help himself, and he's confused, we're in a serious situation now. But his ability to talk to me tells me that he's breathing and he's not sustained an injury, he's not bleeding into his neck, he's not got an obstruction in his throat, he didn't eat a piece of licorice while he was hiking and choke on it, and that was the issue that rendered him unable to help himself on the trail, things like that. Is anybody here medical? Okay, so a little bit of medical people here. Nick's going to show you an emergency. There's kind of 2 things that even the lay public can use. This is called an emergency oral airway kit. You may see these if you buy a little med kit. It may come with one. So we're going to cover it because they're included in a lot of med kits, so you understand its function. This is not something that is
strictly necessary.
Is going to be necessary in a lot of situations, but if you buy a first aid kit or a medical kit, you may see this in it. So tell us what it is and how we use it, Nick.
Basically, the only time this is ever going to come into use is when you have a patient who cannot protect their airway on their own. He mentioned, if the patient's talking to you and they're able to, carry on a conversation, even if they are confused, this is probably not applicable. Reason being, you put this in somebody's airway, they likely have a gag reflex intact, in which case you can cause a lot more problems. If you cause them to gag, they're laying on their back, they puke, you don't want them aspirating that. It's caused a lot of further issues. But in the instance that you come across somebody and they're not talking to you, maybe they're still breathing, they're not dead yet, but you can tell they're definitely in a bad place. These can be applicable. They come in a whole varying group of sizes here. You can measure them going from, if a person's laying flat, you can measure them going from their earlobe. They call this just to the angle of the jaw. You're going to measure them. It goes inside the mouth, and this just, all this does is it's just meant to keep the tongue out of their airway. It's got little channels on there, so if I was to stick this in my mouth, I can still breathe around it. If somebody's laying flat, you don't want their tongue falling back in there, causing an occlusion, just making it harder for them to breathe. That's the last thing you need. Kind of a basic, but it's often used in conjunction with the BVM there.
This is the standard size that you'll see in most med kits because they're meant for adults. So they're not going to give you the giant one for somebody that's got a really big mandible. They're going to give you this basic one. Most med kits aren't going
for babies.
Yeah, most med kits aren't going to come with a variety of them, but we wanted to show you what this was just to give you an example. This is something that in a lot of search and rescue stuff I have maybe used once, and I would only put this in an unconscious person. So for instance, if I had been out foraging for mushrooms in the mountains here, I had fallen, I was unconscious, and Nick and Ellie were out hiking, they found me, and they needed to throw me on a litter, but I was breathing, but not able to talk to them, not able to interact with them, not able to move, and they needed to throw me in a litter like this one, or a litter that they made out of their backpacks. They may put this in because as I'm laying flat, I may kind of be doing this almost like apneic respirating, where I'm kind of gargling on my tongue. They put this in, that opens up the back of my airway, so I'm breathing on my own, and I can keep breathing while they're trying to get me out of that scenario. This is something that in general I wouldn't recommend you go out and buy, but if you see it in your med kit, that's what it's for. The intervention that's gonna give you the most bang for your buck is sitting someone upright instead of laying them flat. When we sit upright, some people may have or may know somebody that's got like sleep apnea, for instance. When they lay on their back flat, they snore like crazy. They can't hardly breathe. They're waking themselves up from breathing. But they go to sit in a recliner, and that moves their tongue forward so that the back of their airways opened up. So a lot of times if we can get people into a seated upright position rather than a laying flat position, that's going to open their airway naturally, and then we don't have to worry about making them vomit with something like an oropharyngeal airway. They also make nasopharyngeal airways, little tubes that you can put in the nose that go down into the back of the throat and create that open passage through the nose. Same sort of thing. If somebody's unconscious, you can use that. For somebody that is conscious, you're just going to make them vomit, so just let them keep breathing on their own. Does that kind of make sense?
What keeps it out of place? Is it behind the teeth?
It sits right in front of the teeth. It's got a little flange so that it would just sit right at the front of the mouth on top of the teeth, so
and
it doesn't keep it from going too far.
The hook on the back is actually like hooking behind the tongue, and so it's
Past epiglottis?
No,
not past epiglottis. No,
keeps it just up. You're going back just behind the soft palate, keeping the back of the tongue just hooked up so it's not dropping down.
Yeah, but it creates enough pressure because the tongue is trying to move back naturally. It creates enough pressure that it'll push against their teeth, and it'll kind of pull into their teeth from the tongue trying to sit back. So it'll usually hold itself in place as long as you've got it seated relatively appropriately. Does that kind of make sense? So we've treated hemorrhage. We need to address airway to make sure the patient's breathing adequately, to make sure there's nothing in the mouth, in the throat, and to make sure that there's no injuries to the neck that are preventing them from being able to breathe.
You're going to sit somebody up, aren't you worried about C-spine?
Yeah, so C-spine is a consideration that is important, but in most of these applications, the question becomes...
not so much paralyzation, but life or death.
Yeah, if this patient's in a position that we're kind of talking about here in like a survival situation, in most cases, C-spine is going to be a secondary consideration to trying to get them out of the situation that they're in. If you have an unconscious patient, C-spine is definitely a consideration because you don't know and they're not able to give you feedback. I think a lot of people that are conscious and awake, if they're able to tell you they don't have severe neck pain and they're able to move their head and their neck, then that's a person I'm probably not going to put in C-spine in a cervical spine restriction of some sort, because I need them to be able to move, and I need them to be able to help me as much as they can to get them out of the situation that they're in, so that they don't die and so that I don't die trying to help them get out of that situation. That's a great question, but C-spine is usually a secondary consideration after we have addressed these things. Does that kind of make sense?
It's changed the last 20 years. 20 years ago, it's always like, first thing you do is C-spine.
That's not to say it's
Yeah.
not important.
Yeah.
It's
It
just
is.
it's take into consideration where you're at. If you're at a place where you can get medical help within 20, 30 minutes, even an hour, and the patient's not in a position that they're looking like they're going to die immediately, then it's okay. You can bide your time. You can have them stay still. I think we're focusing on it where really that you don't have the option of medical help coming to your aid.
Yeah. And if if you're trying to protect their C-spine and you're trying to get them 3 miles down a trail, for instance, how are you going to immobilize their C-spine if they're going to help you hike themselves out? Putting them in a makeshift splint that we can do, for instance, with a SAM splint like we're going to be using here in a little while, where we put that on, we cross it over, we open up their neck, and we put them in that. That person's not going to be able to effectively maneuver on a trail. And if they're moving their neck on their own, they're feeling comfortable and they've got an ankle fracture, I could care less about their C-spine. I need to stabilize their ankle and figure out how they're going to help me get them down the hill. Does that kind of make sense?
What would
So,
you do if they're laying there and they say, yeah, my neck really hurts?
so if it was me, I'd probably put them, I usually carry a SAM splint when I'm doing, when I'm out hiking on my own. I don't have a SAM splint with me. And if they were saying that their neck hurt, I would be trying to make it
Make a decision on if it's safe, if it's okay to move them,
Yeah,
if you have an option.
it's a little tricky because I think, in my situation, I'd be pushing on their cervical spine. I'd be asking them to move and see if they have a decent range of motion. And I'd be making sure that they didn't have signs of paralysis or spinal cord injury. And then we'd be moving down the hill and we'd worry about the C-spine later so that I could get them out of the life-threatening situation that they're in, basically. Does that kind of make sense? The vast majority of people that have some neck pain after a fall are probably not going to have a spinal cord threatening C-spine injury. And much more important is addressing the wounds, the orthopedic injuries that are going to prevent you from getting them to where an ambulance can help you, or getting them to cell phone service so that you can get them to the hospital, basically.
C-spine's not going to matter if they're dead.
Exactly.
What are the signs of a C-spine injury?
So, signs of midline neck pain, so pain along the bony prominences of the neck, pain with movement of the neck. Technically, if they have difficulty moving or feeling in their arms or their legs, that can be an indicator of spinal cord injury potentially. If they are unconscious, not breathing, you just don't know. Like if they're not able to help give you some of these cues, you're just not sure. So in an unconscious patient, when I'm on a search and rescue operation, if I'm, just ground pounding looking for a lost person and I come across an unconscious person, I'm usually putting them in some sort of C-spine protection because that patient can't help me move them anyway. And I have to figure out a way to get them down the hill by myself or with my team. And so usually those patients, I'm protecting their C-spine. In this situation, we're kind of talking about you have your pack, you're hiking, you're mushroom foraging, you're out on your own. C-spine is going to play second fiddle to all these things. And the reality is somebody with a C-spine injury that happens at the top of that mountain there with one person out hiking finding them, that may be a person that has spinal cord injury in order to not die on the top of that mountain. So we'll talk about hypothermia in just a little bit, but that person's going to succumb to hypothermia if they're not able to move themselves, and that's going to kill them within a matter of days anyway, if not hours. So even if we're not talking about massive hemorrhage like we talked about in the first point of our March mnemonic, there are other environmental factors that are going to kill them within hours or days. So a thing to consider here, and a thing that we're always considering, especially in the setting of like mass casualty with multiple patients that are injured, is who is going to survive and who is not. And these patients have injuries that happen naturally, so some of these injuries may not be preventable. If somebody has a C-spine injury, that has already happened, and you got to do your best to get them out of there without causing any more injury than you can. And sometimes that means getting them out without C-spine immobilization in place. Does that kind of make sense?
There may not be a perfect solution that we're kind of thinking of.
Yeah.
It's usually what's the best we can do with an improvisation to benefit all parties involved.
And usually, and especially if you're by yourself, C-spine immobilization is not going to be a functional option for you. On the off chance you are carrying a SAM splint, somebody's got a broken tibia in their lower leg and they can't walk, do you want to use your SAM splint to immobilize their leg to try to get them to help hobble out of the woods with you? Or are you going to put it around their neck and have their tibia flailing in the wind as you try to carry them down? So it's a prioritization of injury pattern, and these primary injuries that are preventing them from moving out are going to use your resources first and foremost. So if I'm carrying this and I come across a patient who's complaining of neck pain and nothing but neck pain, maybe I'll throw this around their neck, we'll secure it down, and then we'll move down the mountain to get them out of there. But if they have an injury to an extremity that's preventing us from moving, this is going on their extremity, and we'll deal with their C-spine as soon as we get to formal medical care. Go ahead.
Is it possible to use like a shirt or a jacket, roll it up real tight and roll it and wrap it around?
You can do a roll. The main thing if you are thinking about securing somebody's C-spine and supporting somebody's C-spine, what we're trying to prevent is flexion and extension at the neck, and as much rotary motion as we can horizontally. And so we can like roll up like a thick jacket or something like that, wrap it around and secure it. The main thing and the most crucial thing as lay people that we need to worry about is tying a jacket around somebody's neck and decreasing blood flow to their head, or in restricting their ability to breathe because we just tied a jacket around their neck. So you certainly can do kind of a foam roll or like a jacket roll around their neck to give them a little bit of support. That's always an option. You just need to be very careful about the neck and making sure that their neck is still open. And before you put anything around anyone's neck, making sure that they're talking to you, they're breathing, if you can, make sure that they're breathing adequately, and make sure that there's no injuries visible on their neck that you need to address. Because if you come up on somebody, they say their neck hurts, you tie a jacket around their neck and you miss the cut on the side of their neck, you're going to have major issues, and it's not going to be too long until they head. So, make sense?
Yeah.
All right. So we're going to move to the next one, which is respirations, closely tied to airway. But the idea here is, are they breathing and are their lungs working? The main test for this is the same as airway. Can they talk to you, and are they making sense? That tells me that they're getting adequate oxygen flow to their brain, and that tells me that their lungs are inflating and deflating to allow them to converse with you. And so the same check for airway goes for respirations. Are they talking? Are they breathing? And the main thing with airway is checking their neck to make sure, and making sure there's nothing blocking their throat or their mouth, nothing in their mouth that they choked on. And then respirations, just making sure they're breathing and talking. These are hard interventions these are hard things for us to intervene on as lay people a lot of times. And a lot of times, even myself, I'm not carrying a lot of equipment. So if you address massive hemorrhage, the patient's unconscious, you address massive hemorrhage, you stop the bleeding in their forearm, you ask them if they can hear you, tell them your name, they can't respond to you, they don't say anything back to you. You gotta say, man, could there be something in their airway? Why are they breathing? You don't see them breathing. Is this patient alive, first and foremost? Because that may be a dead person that's still having bleeding. Alternatively, what are you going to be able to do if they're not breathing? The answers in this situation are usually mouth to mouth. If they're not breathing, if they are not breathing and you're having to give someone mouth to mouth, what is the likelihood that you're going to be able to save that person's life? And in a desperate situation, you can try that. But if you have no cell service, if you're 4 miles up a trail where you haven't seen any other foot traffic, and you've got somebody who's unconscious, not breathing, that's a patient that I'm probably leaving there, and I'm bolting to try to get to a place where I have cell service and I can get someone to come help me. This is something that I carry. This is called a bag valve mask. This is something that I carry in my vehicle first aid kit. This allows me to not have to do mouth to mouth on a stranger, but this expands out here, and you can provide respirations to someone with this little mask that's now on the ground. And it allows you to hook this over here and provide respirations to someone, just giving them breaths essentially. This is obviously big, burdensome, and it's more heavy than anything I want in a backpack, so I don't carry this device unless I'm on a specific medical operation that I'm running. But this is something that I carry in a place like in my car where I can have extra gear, I can have extra equipment, and I know somebody can call 911 and I could use this until Nick arrives in the ambulance. I'm just gonna dust it off.
What do you call that thing?
That's called a bag valve mask.
Or BVM.
BVM, yep. That's a pretty aggressive piece of equipment. Those are kind of expensive, and so for most people, probably a better option than a bag valve mask is a
Little face shield.
A face shield or a little valve that allows you to you seal it around their mouth and you breathe into a little valve that allows you to give them breath without getting their blood in your mouth if they're bleeding or something like that, which is kind of a gross idea in general. If you're saving somebody's life, if it's your family member, probably not a big deal, but for somebody you find on a hiking trail, maybe these are better, more sanitary, safer options for you, trying to give them what they need. Kind of makes sense? So the breathing valves are good options rather than a full bag valve mask assembly to assist somebody with breathing. I think the important thing is if you recognize somebody's not breathing, try to find a pulse, a carotid pulse on either side of the neck, a radial pulse on the front of the wrist here. If somebody's not breathing and they don't have a pulse, that person is dead. And so
It's a great segue into C for circulation.
so circulation is in our March mnemonic is our next. Circulation check is basically after we've already completed the massive hemorrhage, airway, and respirations, we need to check circulation. The first part of a circulation check is to readdress massive hemorrhage. And so if you put a tourniquet, if we have a tourniquet around Ellie's thigh, we have talked to her, she's talking to us normally, she's breathing fairly normally, and she looks to be okay. We've already addressed airway and respirations. We need to recheck our tourniquet because that's what's going to kill her fastest and first. And then we're going to do what's called a sweep. And we're going to try to take clean gloves or a clean hand, and we're going to sweep her arms and sweep her legs and sweep her neck and make sure we don't see any signs of an open wound, and to make sure we don't see any signs of bleeding on our clean hands, or preferably a gloved hand, but in a lot of these situations it's just going to be your hands, so that we can make sure that there's not bleeding from a source that we don't know about. Because if we need to hike Ellie 3.5 hours out of the mountains, Ellie may not last that long if there's a cut on the back of her neck that's bleeding pretty aggressively that we didn't address because we were distracted by the back of her knee. Does that kind of make sense? What this usually involves is getting that person's clothing off so that you can look in their axilla, their armpits, and you can look in their groin creases if they're awake with their consent, obviously. But these are places where we can run into heavy bleeding that can be hiding from us for a long period of time, especially if somebody's out hiking in thick pants or has a jacket on. You're not going to see that bleeding for a while, and you may be distracted by her deformed ankle, and you may not even think to check the opposite side in her armpit to make sure she's not bleeding from the arteries that run through these, what we call junctional areas of the body. Does that make sense? So when we do that sweep, this is where we're going to talk about junctional bleeding. So a cat tourniquet is a great opportunity to stop bleeding in the arm or in the leg. But what do we do if we've got bleeding in a junctional region, which is what we refer to the groin and the armpits? Because I can't put on I can't get a tourniquet up high enough, and I've got a bony prominence here, here, here. I'm not going to be able to compress arteries in my armpit with a tourniquet this high. So my options are top of the arm around the proximal humerus, or the tourniquet's not going to work, basically. So in those situations, your only option really is going to be pressure. And so the key with applying pressure to a wound to try to stop bleeding is local pressure. Because what we see a lot of times coming into the emergency department, what Nick will see if somebody's trying to stop bleeding before his ambulance gets to you, is they took something substantial, they shoved it in the arm, and they went like this. And that'll put a little bit of pressure on various areas in the armpit, but that's not going to stop the bleeding that's happening right there from an artery. And so you're much better off if you can take, for instance, 2 fingers, a piece of gauze, and just push until you find the exact spot where you can compress the artery to stop the bleeding. And I'd say it's been over a year in the emergency department since I've seen any sort of bleeding that came in from home that I couldn't stop with 2 or 3 fingers. That wasn't a massive motor vehicle accident or something like that, that I couldn't stop with 2 fingers in the right place. And so if you have a wound in a junction, you want to go closer to the core, kind of. So if I'm bleeding right there, I want to move my fingers right there and put pressure and hold hard pressure and see if I can get that to stop.
And it's gross.
It's very gross, and it's bleeding heavily, and these are big open wounds, and sometimes they're nasty. But if it's your spouse, if it's your father, it's much less of a big deal, and it's much easier to do. If it's a stranger, get in there and do it if you can.
So you always go the direction toward the heart?
Yeah, so you want to move closer to the heart, essentially, because what you're trying to stop in heavy bleeding is arterial flow. You're trying to stop arterial flow. And arterial flow is moving literally from right here out. And so if you got to bleed here, you want to put pressure here. If you've got to bleed here, you want to put pressure here. If you've got to bleed here, you want to put pressure here. Does that make sense? Just proximal or closer to the heart than where the bleeding is happening.
But never put the pressure on the wound.
Sometimes you can put pressure on the wound or like right next to the wound. I'm usually going just right next to the wound site itself and just applying good hard pressure there. And if if I've got a wound, I don't know, if I've got a wound that's, I don't know, if I've got a wound here, I'm usually not putting my fingers in the wound because A, that's gross, and B, that's going to hurt a lot, and C, that's gross. And so I'm going to go just above the wound, and I'm going to put pressure right here. And if I'm still getting squirting bleeding out of there, I know I've not compressed the artery that is bleeding, so I'm going to move my fingers to the side and put hard pressure right there and see if that bleeding stops. And that's going to be within 2-3 seconds of you applying pressure. That bleeding is going to stop. You may still get a little oozing because we've got veins and we've got arteries, right? But if you got a little bit of oozing, if I've got a big nasty cut through the axilla, through the armpit, and I've got pulsatile bleeding out of there, and I put pressure down and that pulsatile bleeding stops, even if I've got a little bit of oozing, I'm not moving my fingers. Or I'm identifying that spot, I'm having myself, the patient in this situation, put the pressure there, and then just hold, and let's get out of here, trying to hold the pressure in that area, because I don't have the option for a permanent solution like a semi-permanent solution while we're moving like a tourniquet, so we need to have pressure applied there. Does that kind of make sense? Okay. Pressure is going to be the key when we're talking about junctional bleeding. So this is all to say with circulation, we're doing sweeps of the arms, the legs, and the neck, and we're checking the armpits and the groin to make sure we don't have heavy bleeding in those areas. That's particularly important in people that have basically like penetrating injury or high mechanism blunt injury. If somebody fell off an 80-foot rocky shelf and you find them at the bottom of that cliff, that person may have nearly ripped their arm off. They may have a huge, horrible injury in one of these junctional regions, but you may not even see it because they're unconscious, you're panicking, and they have a puffy on. Does that make sense? So you gotta check these things, which is why if you remember the March mnemonic, it's just, what do I do first, second, third, fourth, fifth, and then how do we get out of here? Does that make sense? Go ahead.
Yeah, what about use of clotting agents?
Yeah, so hemostatic dressings are great. So the question was, what about clotting agents? And in a junctional injury in the field, big fan if you have a hemostatic dressing. My guess is a lot of you, when you're out hiking, foraging for mushrooms, you're probably not carrying a hemostatic dressing. I carry them in my car bag, and I carry them in my search and rescue kits because those can be really valuable in those situations. The use of a hemostatic dressing still requires application of pressure. So I'm putting a hemostatic dressing. A hemostatic dressing, if you don't know, is basically gauze that's basically impregnated with a clotting agent in the gauze. And so you put that gauze in the wound, and any blood that hits it just clots. And so you can stop the bleeding. You can essentially kind of create a seal on the wound so that bleeding cannot continue. The problem is The problem you can run into is that with a hemostatic dressing, a lot of times even if you block that blood from coming out, if you have an arterial bleed, the pressure from the artery is enough that it's going to continue bleeding internally. So if you place a if you've got a big armpit laceration, it's squirting blood, you put a hemostatic dressing, you fill the wound with that hemostatic dressing, and you have them hold like this for 30 seconds, and then you lift it back up and you're like, oh, the bleeding stopped. The problem is they could probably put about 2 liters of blood into their armpit before you'd start seeing swelling. So they could essentially go into cardiac arrest before you realize that they were bleeding internally. So it's still crucial to identify where's that bleeding coming from, where can I place pressure to stop the bleeding, then place your hemostatic dressing, and then still hold the pressure there to try to prevent internal bleeding. Does that kind of make sense?
Just because you don't see it doesn't mean they're not bleeding.
Yep. So hemostatic dressings are great though, and especially for venous bleeding. For instance, the scalp. If somebody has a laceration to their scalp, they've got a big head wound, the blood vessels in the scalp are coming from all different directions. So it can be very hard to stop bleeding in a scalp wound. And so I love hemostatic dressings for lacerations to the head, because you can just press that hemostatic dressing into that scalp wound. Usually that's venous bleeding that's just oozing and oozing and oozing. And then you can get good control of that bleeding. And you can even put the hemostatic dressing on and then put their hat back on them just to hold it in place while you get them out of there. Does that make sense? So use the resources you have with you to kind of help you. I've put a lot of hats on people with head bleeds after we've gotten the bleeding under control. And that's just my securement device, because I already know that fits over their head. It's going to hold things in place. I can pop it off and recheck, and then we're good to go. Does that make sense? Other questions? All right, we're going to move to our last one, and that's hypothermia. Does anybody have a guess at what temperature you can start to develop hypothermia?
The ambient temperature or the body temperature?
Environmental temperature.
Yeah.
Yeah.
80,
What's that?
80.
Yeah, so it's up to about 80 degrees actually. And so there's a lot of cases of hypothermia in 65, 70, 75 degree weather. Obviously that's still much lower than your body temperature, which is 98 degrees. But hypothermia is a huge risk and can kill people very rapidly. And interestingly enough, we're actually addressing hypothermia with each step of our March mnemonic before we get there. Because one of the most rapid ways to lower your body temperature is to bleed. You're losing internal body heat with every drop of blood that you lose. So if we can stop that bleeding, we can get better control we can prevent hypothermia down the road, and we can optimize our situation to try to get that patient out of there. Go ahead.
Do you want to talk about like shock with hypothermia? It's kind of just how it leads to hypothermia.
Yeah, I mean, just in terms of lowering core body temp. Yeah. So if we lose enough blood, we can go into shock, which is essentially like people call shock like being in shock, but when I think of shock, I think of low blood pressure. And we lose enough blood, our blood pressure gets too low, and our body can no longer regulate temperature. But we also lose so much heat from our body from the amount of blood that we've lost that our core temperature drops. And then that can, when we think about this in medicine, I worry about the kind of the lethal triad of bleeding, which is low body temperature leading to coagulopathy. So essentially, if we lose blood, our body temperature drops. And as we lose blood, while our body temperature is dropping, it makes us more likely to bleed. And so this is a cycle that we get into, that the lower the body temp is, the more we're going to bleed. And the more we bleed, the lower the body temp is. So you can imagine how people just spiral into this cascade of death, essentially, when they're bleeding heavily. So we got to be really careful that we're controlling bleeding and we're trying to control body temperature. The reason hypothermia comes at the end of the March mnemonic is because for our circulation checks, for evaluating our airway, for our massive hemorrhage management, we need to expose parts of the body, and we're not worried about body temperature, because if we're trying to keep the patient warm and we miss something that's bleeding or something that's broken, we have to start all over and we have to unwrap them again. So usually when I come across somebody that's been seriously injured, I'm doing my circulation checks and then we're wrapping them back up, zipping up their puffy, putting their hat back on,
Keeping them warm.
getting their shoes back on, things like that. Does that make sense? So hypothermia is crucial, and if you find somebody in the woods that's unconscious or has been there for more than 12 hours, in all likelihood their body temperature is already low and you need to get them warmed up as soon as you can, but that's only after you've already addressed the M, A, R, and C in your March mnemonic to make sure there's no life-threatening injury that's going to kill them or injure them while you're trying to get them to safety. Make sense? Okay, and then the last step there at the bottom is we need definitive care. And that's the ultimate goal of using this March mnemonic is where are we going to be getting this person so that they can get help? Because who here is comfortable sewing up a 16-inch laceration that goes from the armpit down into the side of the chest wall? Yeah, me sometimes, but those are nasty injuries that need definitive care from a medical professional, a hospital, an ambulance, things like that, in order to get control of them. So we need to really dial in from the beginning. Is our scene safe and where are we headed? Because if you can have that patient sitting there, bleeding stopped, breathing, in warm layers, and you can call Nick's ambulance and get him to you where you're at, just do that. Run through the March mnemonic to make sure they don't die. Check these boxes in your head, call the ambulance and get them there, perfect. Then we don't have to worry about walking them 3 miles down the hill, which is going to be a huge problem for you. Does that kind of make sense? Okay.
Well, and what does definitive care look like too? Oftentimes, I don't consider myself definitive care. We get there, we got to get them to the ER. Oftentimes the ER isn't definitive care. In a lot of these circumstances, they require surgical intervention. It's always just kind of getting them to that next level, making them somebody else's problem.
Yep. So for you, Nick's ambulance is your definitive care. And for Nick, me in the emergency department, I'm Nick's definitive care. And for me, the trauma surgeon in Spokane is my definitive care. And so we just got to get them to the next step where we can walk up that hierarchy of what level of care do they need. And if you're not sure and you do these things and you get Nick there, you've done amazing. And if Nick gets there and he's not sure and he gets to me, he's done amazing. And that patient's still alive and they have injuries that hopefully, and then they have injuries that we can address at that next level of higher care. Does that make sense? So this whole time you need to be, and from the get-go you need to be thinking, can I call 911 or is that not an option for me? And if that's not an option for me, where can I get them to call 911, or where can I get them so that the ambulance can take them away from me? Because I don't want to be doing this any longer than I absolutely have to, right? And that's what I'm, even as an emergency doctor and a wilderness doctor, that's what I'm thinking anytime I'm taking care of somebody in the woods. How can I get this patient out of my hands to somebody with more resources as soon as humanly possible? Does that make sense? All right. So with the rest of our time, we're going to do a little bit of demonstrating, and then we're going to have you guys work on taking care of the most common type of injuries in a survival scenario, in a kind of a backcountry scenario, which is orthopedic injuries. It's fractures in the arms, it's fractures of the legs, dislocations, things like that. And the key to managing those so we're kind of moving on from the March mnemonic here. This is our life-saving care. If you remember that and you think about those steps and you just check those boxes, you're gonna at least, hopefully you're gonna save somebody's life, right? But a lot more often you're gonna run into somebody who's been there for an hour or two and they rolled their ankle and they don't feel like they can walk. And so a lot of times these are more minor injuries, but they're much more common and they're more likely for you to run into. So we're gonna be working with these SAM splints here just to kind of show you how to secure an injury, how to provide somebody with a little bit of support so that you can try to get them out of wherever they were injured to get them into Nick's ambulance, essentially. And so we've got a few more people here than we were expecting, but that's okay. We'd like you to get into kind of some small groups so that you can actually put some of these splints on each other. So if you're okay, like kind of getting in maybe groups of 3 or 4 with as many people as we have here and just splinting one another. We're gonna do some demos. If Ellie can come up here, we're gonna do some demos on how to put these splints on, but we're going to have you kind of doing them as we go, just so you get a little bit of support. And the thing I want you to remember is, this is big, it's not particularly heavy, but essentially this is an aluminum support material inside a foam sheath so that it's not sharp and injurious. So this allows you to basically fold this up in whatever shape you need to support something. You can fold it this way too, and when you fold it this way, it gets really rigid, and when you flatten it out, it gets really malleable. It's kind of handy stuff, but I don't carry these when I'm hiking. But the idea here is, if you know how to splint somebody and support an orthopedic injury, you can do it with sticks and t-shirts, or you can do it with your jacket and a good set of sturdy sticks if you're out in the middle of nowhere. So think about that. You don't have to carry a SAM splint with you. You just have to understand that somebody that has an injury in their leg that's 16 miles out in the backcountry needs some support so that you can try to help them get to where you have cell service again. And if you can do that with a set of sticks and some cloth or extra material from your backpack, great, do it. You don't have to carry a SAM splint. This is just to demonstrate the idea of what we're looking for in stabilizing an orthopedic injury so that someone can help you get them out.
To be aware of new videos like this one, be sure to subscribe to the Preparing for the Time of Trouble channel. For more free videos and downloadable audio podcasts, as well as handouts, go to www.preparingforthetimeoftrouble.com. Topic categories include recordings of live seminar presentations, country living, sustainable gardening, homestead remedies, how to be self-sufficient when the grid goes down, wild edible and medicinal plants, hydrotherapy, and end-time Bible prophecies. To take advantage of these free resources, go to preparingforthetimeoftrouble.com.